Good afternoon, and welcome to the UPMC Children's Hospital of Pittsburgh Center for Rare Disease Therapy webinar series. My name is Cate Walsh Vockley. I'm a genetic counselor in the Division of Genetic and Genomic Medicine, and along with Dr. Lina Ghaloul Gonzalez, today we're going to be talking about our work with the Plain community in Western Pennsylvania primarily. If you have questions as the seminar continues, please submit them online and we will address all of those at the end of the presentation. So we have no conflicts of interest to disclose related to this presentation. So as I said, Dr. Ghaloul Gonzalez and I work with the Plain communities, and I'm going to start by giving a little bit of background on the derivation of the communities and what we mean by Plain communities. They came from Central Europe, primarily Switzerland, Eastern Germany, in the 1500s as part of the Reformation, religious Reformation that was happening in Central Europe at that time. Currently, there are about 2.1 million members of the Anabaptist communities worldwide. There are three main groups that happen to live here in the United States: the Old Order Amish, the Mennonite, and the Hutterite. Hutterites are primarily in the upper Midwest and into Canada. Old Order Amish are spread across many states, and then the Mennonites are also spread in a number of states. As far as Pennsylvania goes, which is where our focus is, of course, there are about 87,000 Amish individuals. Many are clustered in certain areas of the state: Lancaster County, the New Wilmington area, the Punxsutawney area. And there are Mennonites. It's a little harder to come up with a number, but about 51,000 individuals who are Mennonite in the Pennsylvania population. Oops. This is just a nice heat map of where the populations live. I think many people think of Plain communities, what we call Plain communities, Amish and Mennonite, as living in Pennsylvania and Ohio. But as you can see from this map, they've really spread and live in many of the states in the country with significant populations in Indiana, Wisconsin, New York State, and others. And you'll see the relevance of the work we do in terms of where the clinics have developed to serve this patient population. This is just a summary of data from 2018 is the most recent data that was available. There's a program at Elizabethtown College in Elizabethtown, Pennsylvania called the Young Center for Anabaptist Studies. And there is a tremendous amount of data that they accumulate on the populations. And you'll see that Pennsylvania has one of the largest populations currently of individuals of Amish ancestry. You'll note that we talk about settlements, districts, and then overall population. Settlements are large groupings of individuals from this population. The districts are typically church districts, smaller groupings of families that attend church services, typically in a home. So once the family, or once the population starts to exceed the ability to have church services in a home, the population or the district will split into two districts. Right now there are many districts in Pennsylvania and other states. Ohio certainly has lots of folks from the Amish community. One of the things that's interesting to us as geneticists who study the Plain community is that it is a large population, and it's also an isolated population. So in terms of genetic variation and clustering of genetic changes, it's an easier population than the general population in some respects to study. You'll see here, starting in the early 1900s through, this data is from up to 2017. The population doubles approximately once every 20 years. So it is a growing population. And the next slide is just a photograph that shows a family, a typical Amish family, perhaps going to shopping or church services or whatever, but they usually have, we do have smaller families certainly, but many of the families have large number of children. I mentioned church districts. This is a photograph of people who are or the buggies of people who are attending church services. That looks like a house in the background, or a church, but I think in fact it is a house or a home. The buggies are interesting because depending upon where you see Amish individuals, you may see different buggies. There are white tops, yellow tops, the black tops you see here. Different colors denote different denominations or communities of plain community. Most of them now have, you can see in the back of this slide, most of them have some kind of safety reflector on them. There have unfortunately been a fair number of accidents involving the buggies because they are slow moving. The other thing that's unique about the plain community is that until the age of 5, these children typically speak Pennsylvania Dutch. So if we see very young children from the plain communities, we are usually working with the parents to ask questions of the children because they don't understand English. They attend schools through 8th grade, and these schools are typically within their community and taught by a member of the community. So beyond 8th grade, these children have completed their education and are working in the community. They do learn English once they get to the schools. So why are we interested in working with the plain community, or what got us interested in working with the plain community? In about 2015, we saw a patient, a young woman, who came to Children's Hospital of Pittsburgh with a stroke-like episode. And we worked with one of our neurologists at that time, Amy Goldstein, and this young lady was eventually diagnosed with MELAS, and Dr. Ghaloul Gonzalez will talk more about that diagnosis in a bit. But we began to talk to her, and as part of our typical genetics evaluation, we still collect family histories. We learn a lot from understanding what kinds of conditions are in the family, and we noticed that there were a number of individuals in the extended family who were being seen in our hospital system who had not been evaluated or diagnosed. And ultimately, we learned that several of these family members did in fact also have MELAS, because we did an outreach program with the family in the community and analyzed samples from a fair number of the family members. So we began to wonder, based on knowing that these people were part of the plain community but had not been referred to genetics, how many people there might be who are being seen at our hospital. And we did this based on Children's Hospital patients over a period of 1 year. How many patients might be candidates for genetics evaluation and genetics testing, and were they being referred from the plain community population? So we searched the Children's Hospital records for individuals who were either ethnically or religiously from the plain communities. We reviewed those charts and identified, first we identified 303 individuals who were from the plain community that were seen here at Children's. We then reviewed those charts, and you see Sarah Ehrenberg here. She was a medical student at the time and was instrumental in getting this work done. We reviewed those charts and identified 102 of those patients who we thought would be good candidates for at least a comprehensive genetic physical examination and consideration of genetic testing. And of those 102 patients, only 32 were referred for medical genetics. So we began to think about this as an underserved population and look at ways to increase our outreach to this population. So we developed what we call our Plain Community or Plain People Translational Medicine program here at UPMC. It started with Dr. Jerry Vockley and myself, and as I mentioned, Dr. Amy Goldstein. And then Dr. Ghaloul Gonzalez joined the group, and for a period of time, Dr. Deepa Rajan from neurology was also traveling with us to our clinic. We developed a program where we have an outreach clinic at Hermitage. We were in Sharon for a short period of time because of space constraints in Hermitage, but now there's a brand new outpatient clinic building in Hermitage, and that's where we see families. We're typically there on the first Tuesday of the month, and see anywhere from 4 to 8 patients on a Tuesday. In addition to developing our own program, we were aware of certainly the number of clinics that do serve this community across the upper northeastern United States primarily, recalling that heat map that I showed you. Lancaster County Clinic, Clinic for Special Children in Strasbourg, was the original clinic that served patients from the Plain community. And there was a fair amount of work done out of Johns Hopkins by Victor McCusick, looking at this patient population, and Bill Holmes Morton at the Clinic for Special Children originally. There are also 2 clinics in Ohio, in Geauga County and in Mount Eaton, Ohio, a new clinic in Kentucky, a clinic in Indiana, and a clinic in Wisconsin. And these clinics all have become part of what we call the Plain Community Health Consortium. We are an affiliate member of the Plain Community Health Consortium because we don't provide primary care, but we obviously provide subspecialty care, tertiary care here at Children's Hospital. But we work closely with this community. We have annual conferences when COVID allows, and work together on research projects, on identification and provision of resources for families, all sorts of collaborations with this growing consortium as more and more clinics are developed. As for our own program, though, we had to look at ways to establish the outreach that we wanted to do in Western Pennsylvania. This is a population of Amish and Mennonites that is relatively underserved compared to other areas where the clinics are more well established. We do both clinical work, seeing patients for comprehensive genetic or metabolic evaluation, as well as we have a developing research program, and Dr. Gonzalez will talk a little bit more about our research program in a few minutes. As I mentioned, we have our outpatient clinic at Hermitage in Mercer County. We provide medical genetics and metabolism, evaluation and ongoing management, genetic counseling from myself. We have a dietitian who goes with us to all of our clinics. We have neurogenetics available if we need it. There are several other children's hospital providers who see patients in the same facility where we are now, and we can easily refer to GI, cardiology, neurology, other subspecialties as needed for some of these patients. Many of the genetics patients we follow from this community have complex care needs and coordination of care needs, and we're often working with other providers to make sure they get the care they need. So we were reaching out to our healthcare provider colleagues. We did a grand rounds up there. We did some mailings to all of the UPMC providers in the area. But we also needed to let the community know that we were coming to their area. So we tried to do that in a culturally appropriate way. We went to Amish gatherings. They have safety days at local fire halls where they do car seat fittings, those sorts of things. They also do immunizations. They have community health screening programs where we have visited. We did ads in community publications. There are a number of publications that are primarily for members of the Plain community. Just Plain Values is a little bit more broadly distributed, but Dibot, Chaff, and the Budget are very much used by the Amish community. We did some word of mouth. We talked to public health nurses. We had families that we had seen who knew us reach out and let other family members or other families they knew of who might benefit from our services know that we would be coming into the community. And we also did some midwife education, primarily related to working with Dr. Vivekalata when he was here, looking at pulse ox training for critical congenital heart disease newborn screening, because that was not being done by all of the members of all of the midwives that serve this population. So we tried a broad swath of outreach to this community. One of the most important things that we find happens as we go into the communities is that we are providing services locally for these families. These families, as you may know, do not drive vehicles. They hire drivers from the general community to transport them. And they right now are paying more than $1 a mile for transportation. So having something closer to them than needing to drive all the way down to Pittsburgh really helps facilitate them accessing care. We also, as part of UPMC's program for individuals who are self-pay, it is possible to offer services at a reduced price to members of the plain community, because generally they do not have health insurance. Some children with more complex medical conditions do have health insurance, but the vast majority of them do not. We also see patients when they're here at Children's Hospital. We see them outpatient, particularly if they're coming for other subspecialty care. We do see patients for inpatient services. Oftentimes, a child comes in for something that is not specifically thought to be genetic, but as we start to evaluate and see them, we may recommend some genetic testing or further evaluation of other family members, and as I mentioned, reduced pricing for members who are contracted with UPMC and are self-pay. And I think it's time for Dr. Gonzalez to take over the leadership here.
Okay, thank you, Cate. Hi, everyone. So I'm going to talk more a little bit about the research projects that we are working on. This just lists some of the impact that we have on this population since we started the program. As Cate mentioned, improved access to subspecialty care, genetics, and the other subspecialty in the Hermitage Clinic or either here at the Children's Hospital. Family-centered genetic services, clinical or research. So when we see these patients in the clinic, we provide clinical care as any other patient that we see in genetics, but we also have research opportunities for these families to be involved, especially for those patients that we end up not having specific genetic diagnosis or whether it's clinical trial or other research studies. So here there's a list of some of the research studies that we performed, and I will go more with a little bit more detail in the next slides. The MELAS mitochondrial disorder, then we did a study on the propionic acidemia in the Amish population, GUCY2C gene, and PNPT1, and there are other research projects. Genetic counseling is essential in these families, especially they are big. There might be more than one family member that is affected, and we do offer carrier testing for other members from the family or extended family. This is just a picture of a big Amish family, probably on one of the Sundays. So the plain community studies, so these are some of the basic ones, the ones that we did spend a lot of time on. The first one is the MELAS, which stands for mitochondrial encephalomyopathy, lactic acidosis, and stroke-like episodes. Due to common mitochondrial DNA mutation, the M3 to 43A2 gene mutation. We do also whole exome sequencing or whole genome sequencing in the plain communities, and this is mainly for patients that they have undiagnosed genetic disorder or to do population studies so we can compare the genetics between the different communities, Eastern Pennsylvania versus Western Pennsylvania, or the other communities that they are in different states. And we also offer carrier screening. So some of these families, we offer them whether they want to know if they are carriers for specific genetic disorders that we know they are common in the Amish population. Or the Mennonite population, and some of them agree to do that, and some of them prefer not to do the carrier screening. The one that we did recently is an Amish variant propionic acidemia natural history study, and the reason why we did this is propionic acidemia is one of the metabolic disorders that usually present very early in the general population. Usually it's diagnosed with a newborn screening, but we know that propionic acidemia in the Amish can be missed with the newborn screening just because it presents milder. So these patients can have later onset of clinical symptoms. Many of them have cardiomyopathy, and we were looking if there is any specific appropriate biomarkers to tell us which one will develop cardiomyopathy or seizures or lactic metabolic decompensation, and which patients from this community with propionic acidemia will develop other symptoms. The one that we will be working on soon is the Amish GUCY2C variant natural history study, and this is a gene that is cause chronic diarrhea in the, actually it's not the Amish, it's Mennonites. Sorry for the typo there. So just to talk a little bit about the Amish genetics. So it's actually there is advantage of studying genetics in the plain community in general and in the Amish. Usually Amish have somewhat larger families compared to the Mennonites. So they are close population. There is a similar environment that they all live in, and there are large families. So it's easier to do segregation studies and genetic studies. And if you see here, so this is the originating population that we can say this is the population that came, you know, there is this portion here that came from Europe, migrated to North America, and these populations go through genetic bottleneck. So they lose some of the genetic diversity in the community, and over time there is a drift up of the specific mutations in the population. That's what we call founder mutations. The whole exome sequencing that we do is usually with the collaboration with the University of Exeter. It's a Windows of Hope project that they collaborate with different plain community clinic in the US. So we do exome sequencing of some of our families through them. We also discuss functional studies for novel variants or novel genes that they were not known to be associated with genetic disease. We also, the other one that I talked about is the MELOS project. So this is the very first one, and this is the first actual publication that we did for looking for mitochondrial genetic disorders in the plain community. And if you can see here, so one of the genetic counselors worked with us on a thesis on this, and Afifa Irani. This patient here is the patient that Cate mentioned. She came in with strokes. She was around 13 years of age, and we did studies on her, Dr. Jerry Walkley, and there was a neurologist, Dr. Amy Goldstein, and found that she has a MELOS mutation in the mitochondrial DNA, which is seen also in the general population. It's 32438 gene. When we did the family history that Cate was mentioning about, we realized that there are other family members on the maternal side because mitochondrial DNA is usually inherited from the mother. So we realized that there are several family members that they have diabetes or migraines or hearing loss, beside other symptoms that can be seen with this mutation. And when we did the testing, whether they have the mutation or not, many of them have the mutation with different heteroplasmy level. And when we talk about heteroplasmy level in mitochondrial DNA mutations, you can see a representation of the cell, and these you can see the green and the orange mitochondria. So each cell has hundreds to thousands of mitochondria, and when we say heteroplasmy level for 60%, for example, for the mutation, we're saying that 60% of the mitochondria in the cells have the mutation, while 40% does not have the mutation. And the way we did this testing is by doing a test called high-resolution melting assay. So we do have different standards with different heteroplasmy levels. So this first figure is just for the standards with the heteroplasmy level of 40, 60, 80, 100, 20, and then 10 and 5. And here is, we have here AF013, which is this proband, DBS, which is the dried blood spot. And we see that it overlaps with the standard that is 80%. So that tells us that heteroplasmy level in the blood was 80%. When we did the urine, we found that there is overlap with the 100%. So that means her heteroplasmy level in the urine is 100%. And it is not unusual to see different heteroplasmy levels in different tissues, and the higher the heteroplasmy level for the mutation is, the higher likelihood that patient can have symptoms related to the mitochondrial mutation. So that was the very first, and from there we had, this was actually the second family that we did find a new genetic disorder that was not reported in the Amish population. And this was a smaller family, and we have this patient here. He was, I think, 3 years old when we were, when genetics was called for consult. And this patient has immune deficiency and had bone marrow transplant. We found that he has AK2 deficiency. So AK2 deficiency, which or adenylate kinase 2 deficiency, causes what's called reticular dysgenesis, and this is usually presented with severe combined immune deficiency and sensory neural hearing loss. Patients with AK2 deficiency in the general population, they usually die within the first few months of life if they don't get bone marrow transplant. While this patient did survive the first year of life without dying from the immune deficiency. He had some illnesses, but not so severe. So this is autosomal recessive disorder, meaning you need 2 mutations on both sides, inherited from mom and dad, and was not previously described in the Amish, and most patients with reticular dysgenesis that they were reported were German, Dutch, Turkish, Kuwaiti. There was some consanguinity in the families. So we found a novel missense variant, which is written here, and it's a change from amino acid serine to proline. And I don't have all the functional studies here. I just have 1 or 2 slide representation of some of the work that we did. Here there is a protein structure of the gene, the AK2, the protein, where, and this is the location of the serine. It's in a beta sheet of the protein. When it's changed to proline, it makes a kink in the beta sheet of the this part of the protein, and it makes the protein unstable. This is why when we do Western blotting here, you don't see any signal, no band for the patient when we compare to the wild type. Beta-actin should be the same because this is control that we use in the Western blotting. When we did immunofluorescence analysis, we did that on skin fibroblasts and the bone marrow. The green signal is for the AK2, and the blue is for the nucleus. The upper figures here are for wild type, and you can see the green signal for skin fibroblasts and the bone marrow cells, while in the patient, there is barely or no signal for the AK2 in both the skin fibroblasts and the bone marrow. So with these functional studies, in addition to others that they are published, we were confident that this change that we are seeing in the gene is pathogenic. And we were actually, after this patient was diagnosed, the family, he unfortunately passed away from complications of bone marrow transplant at second bone marrow transplant at 5 years of age. But we were able to diagnose his brother at the second day of life because we knew of this patient with AK2, and his brother had bone marrow transplant earlier, was monitored earlier by immunologists, and is doing well. Shifting to another genetic disorder here, this is a big Mennonite family that we were called first to for this patient here who was 13 years old and had multiple hospitalizations for chronic diarrhea and dehydration. The gastroenterologist who called us mentioned that this patient mom also have some history of chronic diarrhea, but not so much hospitalizations, milder than him. But the maternal grandmother, which is shown here, she had history of chronic diarrhea, and she had several bowel surgeries called bowel tapering due to distension of the bowel. So we met this family, taking the family history. We found that there are other family members that they were affected and having chronic diarrhea, and many of them had hospitalization, especially when they were during infancy. So we did what we call field trip, and we went and met the family. There were about 25 family members, some of them affected, some of them unaffected, and we were able to collect samples, blood samples, and do targeted testing for this variant. The way that we found this patient has variant in the GUCY2C is by doing whole exome sequencing. We found this variant, we started doing functional studies, and we wanted to do what we call segregation analysis by testing other family members and see if the ones that they are affected have the same variant and the ones unaffected, if they have it or not. So here with a black filling, these are all patients that they were having the mutation. They were heterozygous. So this is autosomal dominant disorder. So you only need one copy of the one mutation on one of the alleles to cause the disease. So all of these with the black filling, they have the symptoms and they also have the mutation. The ones with the gray, they were patients that they were unaffected, they were healthy, and they did not have the mutation. And here we had two patients or two family members that they had some symptoms or GI symptoms. They were unusual, and they were found not to have the mutation. So it could be his GI symptoms fused to something else unrelated to GUCY2C mutation. So, so we did beside the segregation analysis, we did the functional studies, and this is just to give a quick overview of what the GUCY2C is. So this gene encodes guanylate cyclase, and this is a transmembrane protein that's expressed mainly in the intestinal epithelial cells, mainly in the small intestine. So what it does, it regulates the fluid and electrolytes, and this is why it causes the diarrhea. And it causes the early onset chronic diarrhea. It's autosomal dominant, so there is need with heterozygous mutation, patients have the symptoms. And these, the mutations reported in the literature are all gain of function mutations in various regions of the GUCY2C. Here is, so this is where the membrane, the cell membrane in the intestine, and this is where the receptor is. There are, in healthy individuals, when there is a heat-stable toxin from infection, bacteria, then it can activate this receptor, which increases the cGMP, and this affects two receptors that have a role in electrolytes. So it activates the CFTR and it inhibits the NHE3, and this causes increased chloride in the lumen of the intestine and decreased absorption of the sodium, and that's why these patients have diarrhea. Many of the mutations were reported, so this is a representation of the protein. They were reported in this area, which is called the linker area, and the variant in our patient was in the linker area. So this, beside other studies, functional studies, also give us the segregation studies that we did in the family. Also, we were very confident that this is the cause of the chronic diarrhea in this Mennonite family. Shifting gears here, so we were talking about, looking for novel genetic disorders in the plain community. But one of the things that I will be presenting here is actually a patient that is not from the plain community. She's from the general population. So she's a patient that was followed in genetics for a long time. She's currently 21 years old, but we had her diagnosis a few years ago. So if you see her pictures here, she had this failure to thrive when she was a baby. She has some dysmorphic features, unique facial features, and she has autoimmune issues. So she had hepatomegaly, elevated liver enzymes. She had muscle wasting here. She always had this inflammation in her joints. She had this psoriasis, which is autoimmune in her, and you can see here in the scalp. Her nails, she always, for all the years that we've known her, she always had very thick nails with psoriasis, and she had very bad psoriasis in different areas. So you can see here in her foot, around her G-tube area, and these are also psoriasis. She had, because of the inflammation, she had effusion in her knees, and she needed to have arthrocentesis every few weeks. So this patient was actually, even though she's from the general population, but because of what we knew previously from the Amish, that there was only one Amish, one paper talking about Amish patients with H deficiency, and it was this paper listed here. So there were 10 total patients, and these patients, they have this common mutation. These papers were not published when we did the diagnosis in our patient, but we did whole exome sequencing on her, which found the frame shift mutation and didn't detect the deletion on these exons. So we did additional studies because we thought her clinical pictures fit exactly with what is published for the Amish patients. So we did additional genetic studies, and we found that she has deletion of exon 24 and 25. So that makes her a patient with H deficiency. There are several single reports that they were published over the years, but nothing from this one to the next one. There was the 10-year gap period, and so in this we show how we also benefit from knowing of the genetic disorders in the Amish, and how we can help also patients from the general population. These patients, most of them have failure to thrive, the developmental delay, the dysmorphic features. They all also have lung disease and relative macrocephaly. Then there are other autoimmune issues that they are variable between patients that you can see here. The patient here, it says, had a bone marrow transplant. She is a patient from CHOP in Philadelphia. So at the time we published the paper, our patient didn't have the bone marrow transplant, and that patient had autoimmune issues, resolved after the bone marrow transplant, doing much better. So it was planned at the time of the publication to do bone marrow transplant for our patient. And these are the pictures of the patient after 6 months and a half after having the bone marrow transplant. Even 2 weeks after having the bone marrow transplant, her psoriasis completely resolved. And we can see for the first time her fingernails. She still have some dysplastic fingers, nails on her toes, but they're still growing, but the psoriasis is completely resolved, and her liver function is better, her lung function is better, so she's doing much better. So now we have these 2 patients with H deficiency that had bone marrow transplant with really great results, even though they were both adults. So the question is, do we really need to provide this treatment earlier for the patients that we have, they have H deficiency? And now we can go back to the community, the plain community, and see, any patient with H deficiency that is diagnosed, we can talk about this treatment and probably provide this before they have all these chronic symptoms, and to see if there is even better outcome if it's done earlier. So there is this continued benefit from studying the genetic in the plain community for both the plain community and the general population. One of the also main focuses that other research studies that we are putting a lot of effort in the lab is TANGO2 deficiency, or the long-name TANGO2 related metabolic encephalopathy and arrhythmia. So this is a genetic disorder due to TANGO2, which stands for Transport and Golgi Organization 2 homolog. It's autosomal recessive, and there is several mutations reported, but there is a common European deletion of most of the gene, exon 3 to 9, which is also present in the Mennonites. There are multiple systems involved, and the patients, even with the same deletion, they can have variable clinical manifestations. We still don't know the exact function of the gene. There was lots of discrepancy in the literature about mitochondrial involvement in TANGO2 deficiency. So one of the things that we try to do in the lab is to look for, just because some of the clinical manifestations these patients have can be present in patients with mitochondrial dysfunction, like lactic acidosis, rhabdomyolysis, hypotonia, seizures, and others. So we did have two patients here, P1 and P2, that they were siblings seen here at Children's Hospital, both of them with a common European homozygous deletion of exon 3 to 9, which is also present in the Mennonites. And both of them have delays. That P2 died at 6 years of age. P1 actually just died a few weeks ago. And she had profound developmental delay, hypotonia, seizures, and generalized brain volume loss. The third patient is seen elsewhere and was done in collaboration with Dr. Hatz. So it's compound heterozygous for the common deletion and also for splice site variants. This patient was much milder than the other two patients that they were seen here at Children's. So what we did first, we wanted to see is TANGO2 present in the mitochondria or not. So what we did here is having mitochondrial extract and whole cell lysate, looking at TANGO2 in the cell or just in the mitochondria. And here you can see GAPDH is a control, just to make sure we're doing this correctly. And TANGO2, you can see there is only band for the wild type, while for patients P1, P2, and P3, there wasn't any band. And we expect not to see a band or protein expressed because there is deletion of most of the gene. So we did not see here any protein. With the mitochondrial extract, we also did not see anything, but what we did see in the wild type is there is a band for TANGO2. So that tells us that TANGO2 is expressed also in the mitochondria. So after that, we moved to that, looking for mitochondrial function. And just briefly, this is a mitochondrial respiration that we do using a seahorse instrument, looking for oxygen consumption rate, which is an indicator of how healthy is the mitochondria. So there is injection of several compounds, and what we measure is basal respiration of the mitochondria, maximum respiratory capacity, and reserve capacity. And we did it in two different ways. One is with glucose, the other one is without glucose. And when we say without the media without glucose, that means we are stressing the cells by not providing glucose for the cells. So what we can see here, so P3 is the mildest, really had the basal, maximal, and reserve capacity very similar to the wild type with glucose. Let's say here during, if we want to compare it to the patients, we can say when patients are well, so patient is doing well. So same thing for the cells. P3 did have very similar oxygen consumption rate compared to the wild type, while P1, who was the patient who survived till 16, had less basal respiration maximal and reserve capacity, and P2 is the one who was the most severe and died at 6 years of age, have even worse. Without glucose and stressing the cells, you can see that P3 under stress, who is the milder patient, have abnormal oxygen consumption rate, and you can see it here decreased compared to the wild type. And everything, P1 and P2 is also decreased. We looked at the other way of the ATP production, also using the seahorse. So this also was done. We looked at the ATP that's produced from the glycolysis pathway, from glucose, or from the mitochondria, and then there is the total here. And again, C is the control, and these are the patients. So let's look here first at the mitochondria. So we can see P1 and P2 is decreased compared with the control, because we showed that that there's mitochondrial dysfunction. P3 was kind of similar to the control, but the way that these cells are trying to compensate is by getting more ATP from glycolysis. This is why P1 have increased ATP from glycolysis compared to control. Same for P2 and for P3. So at the end here, so they both kind have similar or even higher ATP to the control. And I don't have the other figure, but we did look for ATP consumption, and patients, even though they have similar ATP to the control, or even in here you can see P1 and P3 slightly higher, but they do use the ATP much faster than the control. And the way of compensation to generate ATP is from glycolysis, because their mitochondria does not work well. So we're still doing a lot of work on Tango 2, trying to figure out what exactly does it do. Does it have role in transporting proteins between organelles or not? And figuring out, how it works. The one thing that the one other study that I would like to just very briefly mention is the Propionic acidemia natural history study. And Sarah Ehrenberg, who was a medical student, put a significant amount of time working on this. So we looked at the Amish patients with a specific missense variant in the PCCB gene. It's a founder mutation. And we looked at 3 different centers at the Indiana, in Ohio, and here at in Western Pennsylvania. And we had a total of 38 patients. And as I mentioned previously, some of these patients are not diagnosed with the newborn screening just because it's so mild. So usually propionic acidemia is diagnosed with the AC-carnitine profile on the newborn screening, and the C3 is where we can say a patient is affected or not. But the C3 in the Amish could be very similar to almost similar to the reference. And here from these 38, 22 were had positive newborn screening recorded in their charts. Some of them, they had repeat was normal, and 16 didn't have a newborn screening. So or not 100% sure whether they had negative newborn screening or it was not just in their recorded in their charts. And from these that they were negative or not reported, 24 out of 38, so that's 60%. These were diagnosed later with propionic acidemia due to different reasons, either family member diagnosed with propionic acidemia or hospitalizations with metabolic acidosis or seizures or diagnosed by cord blood because of family history. This is a very busy slide, but it's just to show with the propionic acidemia, there are different ways of treatment. So protein restriction or no protein restriction, giving formula, special formula, and carnitine CoQ10 biotin. As I mentioned, many of these patients have cardiomyopathy, and we know that many of these patients don't have compliance with the treatment with protein restriction. So from the takeaway message from this slide is for these patients that they were on protein restriction, formula, carnitine CoQ10 biotin, even those ones that they were very compliant, 55% had cardiomyopathy. And with the ones that they were not getting any treatment, it was one here also had cardiomyopathy. So even with compliance, these patients go into cardiomyopathy. We still don't know the reason why, but it could be multifactorial, and we have additional studies that we'll be working on in the future. So this is just the most common cardiomyopathy is the most common clinical outcome in the Amish with the propionic acidemia. We like to obtain cardiomyopathy gene panel in all patients with propionic acidemia in this population, just because we know they can carry other genes that can cause cardiomyopathy, and we have an example of that in a children's hospital with patients who have Titan pathogenic variant beside the PA and underwent heart transplant. And there are specific recommendations, including echo at the time of the diagnosis. And these were from the guidelines for propionic acidemia that was generated for any patient with propionic acidemia. Just to, I want to give some questions to, some time for questions. There is still a long, steep road to learn more about the genetic disorders in the plain community in Western Pennsylvania. We did diagnose the new genetic disorders. We did functional studies. There are others that they are still in the work, and we have a few projects in collaboration with other clinics or University of Exeter that we're working on, but there is definitely a lot of work and things to learn from. And here I would like to acknowledge everyone. Of course, Cate and I are, the main ones working with the plain community. So she does a lot of coordination, genetic counseling, testing, and she talked about her part earlier. Lots of students work on different projects related to the plain people, and of course, Dr. Jerry Vockley and the people in his lab and my lab, we work together continuously. And with that, we're happy to take any questions.
Questions coming through. Maybe while we're waiting for questions, I can just mention that because we do clinical outreach, if you feel like you're following families who have conditions that we can evaluate or they have undiagnosed disorders, please don't hesitate to consider referring them to us or to one of the other clinics if you're closer to get comprehensive evaluation. I think for contacting us, you can probably send a note to the Center for Rare Disease Therapy, and they'll find us here at Children's. As Dr. Gonzalez said, we even will go out to family homes to see complex situations. So we're happy to provide services for this patient population.
Yeah, we're happy to collaborate. Yeah, as Cate mentioned, even do trips if we need to see families that it's harder to come in here to Children's Hospital.
And it appears that there are no questions at this time. So please let us know if you have questions and follow-up after the webinar. And otherwise, thank you so much for attending, and we look forward to seeing these families.
Thank you.